Today, yes, we will now be discussing your liver function. Yes, your liver function, we will focus on your forced liver and the production of your bile. Okay, so your liver has parts, wherein you have the right and left lobe, the liver, which is separated by your falciparum ligament. No? This receives blood from your aorta, and then, okay, also, no, it transfers blood through your inferior vena cava. It also associated parts also of your other organs is your gallbladder, okay, which is the storage of your bile, which is produced by your liver. Okay. You have the microstructure of the liver. You have the hepatocytes, wherein you can see them as into a hexagonal form. Okay, as you can see here, they are in hexagonal form. No? That's your hepatocytes. Okay, then you have the main blood supply here. You have the hepatic artery, and then branch of your portal vein. So your portal vein is the central circulation of your liver. So this portal vein will now vein into your inferior vena cava. Okay. Within that hepatocyte, you know, a an area wherein your bile is also transmitted to your other parts of the body, such as your gallbladder, to be stored. You have the branch of the bile duct, okay, and bile canaliculi. Okay, your bile duct, no, is one of the portal triad. So your portal triad consists of your bile duct, portal vein, and your hepatic artery. Okay, yeah, this is a microscopic view of your liver, okay, based on the microstructure. So you can see the hepatocyte, no, which is this one, hexagonal cell. Okay, then you have the central vein, the bile duct, no, hepatic artery, and the portal vein. Okay, how do you differentiate your vein into your artery? Okay, you can see this one here in this structure. You can see the portal vein has two. It has a thin, no, basement membrane, and your hepatic artery has a thick one. Okay, and then your bile duct. You can differentiate your bile duct as to your hepatic artery, or your bile duct doesn't contain any RBCs like your portal vein here. These are RBCs. Okay, inside that, the third one, the hepatic artery here doesn't have any RBC. So yeah. Okay. Then copper cells. Copper cells are known to be your macrophages, which are found within your liver. Then sinusoids. Sinusoids are small areas wherein your bodily fluids also flow into, also your canaliculi, then the portal vein, hepatic artery, and then the hepatic vein. Okay, what are the cells found inside your liver? You have the copper cells. No, they are derived from your monocyte. Okay, they contain lysosomes with hydrolytic enzymes, immunoglobulin, and complement receptors. Secretes interleukin, tumor necrosis factor, collagenase, and prostaglandin, which contribute to the inflammation. Okay, when your organ is being invaded by a pathogen or an outsider. Okay, then you have the hepatocyte, which is the main cell of your liver. The major function of this cell performs most of the metabolic processes and synthetic function of your liver, such as the production of your bile. And, ano pa? Detoxifying your blood. Okay. Other cells that you can find here, you have the stellate cells or E2 cells, no? Sites for storage of your fat-soluble vitamins. So what are your fat-soluble vitamins? You have vitamin D, no? A, D, E, and K. Okay? This vitamin A, those are your fat-soluble vitamins. Okay. Synthesis of collagens, two fibrosis and cirrhosis, no, is mainly regulated by your stellate cells. Okay? Then, synthesis of nitric oxide, which regulate intrahepatic blood flow, is also the function of your stellate cells. So next is your oval cells. Your oval cells, no, are liver stem cells which involve in the regeneration of your hepatocytes and bile duct after liver injury. So your oval cells, no, is mainly responsible with regards to the regeneration of your liver. So kaya pwede daw mag-donate, no, ng liver ang isang tao sa ibang tao because your liver can regenerate. No? The only organ that can regenerate itself, that is because of your oval cells. Okay? So yan, kaya pwede tayo mag-donate na part lang ng ating liver if it's healthy. Okay? So your liver has many functions. Okay? So you have the biochemical hepatocytic system first, which is responsible for the vast majority of all metabolic activities. Then you have the hepatobiliary system, concerned with the metabolism of your bilirubin. Then you have the reticuloendothelial system, which is involved in the immune system. So your biochemical hepatic system, hepatocytic system is responsible for vast majority metabolic activities, such as your, no, um, such as your uh, detoxification, no, detoxification. And how is that so? That detoxification, no, mostly, no, by your by the blood circulation. So those drugs, no, those substances that are found in your blood, no, can be detoxified, especially those agents that are harmful to your body, no, is being detoxified by your liver. Right? They are being eliminated by your liver. No? Some of the drugs can also be eliminated by your liver or degraded by your liver, kaya meron tayong first pass metabolism na ginagawa ni liver to your drugs. Okay, so some of your drugs are being kaya hindi fully, no, na na-absorb ng katawan natin yung binibigay na dosage ng gamot. Kasi nga, nagkakaroon pa tayo ng first pass metabolism, which is a biochemical hepatocytic system of your liver. Another is your hepatobiliary system, which is concerned with your bilirubin. No? Mainly, this is the production of your bile and the degradation of your bilirubin from other metabolic processes. Okay? Then you have the reticuloendothelial system, which is involved in the immune system. So your liver also function in the immune system. How? No? Your liver is an area for detoxification and, no, also fighting microorganisms. So itong pa, no, tinatry na ni Kupffer cells, your Kupffer cells, and other, no, immune inflammatory cells, no, counteract, no, the pathogen within the liver. Okay. What are the other functions? No? Yan, detoxification, metabolic function, secretion of bile, and storage of what? No? Your some of your fat soluble vitamins. Okay. Storage of your glycogen, mainly, no, for your future use. Okay. So, in detoxification of blood or excretion, no, phagocytosis by your Kupffer cells. No? Then metabolism and excretion of steroid hormones, drug and foreign compounds, no, sinabi ko yan. Production of urea, uric acid, and other molecules that are less toxic than their parent compound. So, being a toxic compound, no, dinidegrade nila those molecules into a simpler form which can be excreted to your urine, no? Like your urea and uric acid. Na-discuss natin ito sa non-protein nitrogens. Okay. Metabolic function, you have the carbohydrate metabolism. Okay, they degrade carbohydrates, no, to form smaller molecules to be used in your energy, no, production of your body. Then you have the lipid metabolism. How? Okay, for your lipid metabolism, no, they degrade your lipids as to the needs of your body. So if ever that you need, no, energy to perform work, such as you don't have enough capacity to degrade your enough capacity like your carbohydrate stores, then your body will shift into lipids. Okay, then no, it is being metabolized by your liver. Also, this liver can produce lipids through excess carbohydrates. Okay? Then protein metabolism, same goes to this, like your lipids, and then your hormone metabolism. Okay, what hormones are being produced here? No, parts of your erythropoietin. Erythropoietin are produced in your liver, okay, and some other hormones. Okay, secretion of bile. So the secretion of bile or bile, which is the liver, plays a major role in conjugation and excretion of your bilirubin. Okay, your bile is being secreted, then it's being conjugated also by your liver to produce bilirubin, which is mainly, no, used by your body. Okay, synthesis of bile salts or bile acid is also a function of your liver. Then storage, yan, vitamin A, glycogen, vitamin B12, and iron are being stored by your liver. Okay, bile. This is a main component, no, of the liver, which are main, no, secretion of your liver, which is composed of bile acid, lecithin, cholesterol, bilirubin, urobilinogen, and electrolytes. It is important in lipid digestion. So, if ever that you don't have enough bile, no, your body will accumulate lipids. Okay? Your bile is an emulsifying agent. It will degrade your lipids to simpler molecule to be used up by your body. Okay? Then, no, cholic acid and deoxycholic acid. Next is your bilirubin, a bile pigment that results from a catabolism of heme moiety of the hemoglobin molecule due to an age or trauma. Okay? The aggregation occurs in the spleen, bone marrow, and liver. So mainly your bilirubin is not only found in the liver but also on some organs such as your spleen and bone marrow. So your bilirubin plays an important role in heme, no, in RBC production. So bilirubin is part of your RBC. So if ever that your RBC died, or as I said, RBC is being goes on apoptosis, no, it will release bile. Also, hemolysis, no, of your blood can also cause bilirubin to be released in the blood. Okay, kaya we don't use, no, hemolyzed specimen with regards to bilirubin determination because bilirubin is within your RBC. Okay, you have different types of bilirubin. So you have B1 and B2. So what are the characteristics of B1 and B2? For B1, it is non-water soluble. So it is not soluble with water but soluble with alcohol. Okay, while your B2 is soluble in both water and alcohol. Okay. B1 has a high affinity with regards to your serum albumin. Okay? Then your B2 doesn't have any affinity to serum albumin. Okay, so your B2 has a high affinity with no affinity with regards to serum albumin. Then, no, with lipid membrane permeability, those who can cross within the lipid membrane, no, B1 is the most applicable with regards to the lipid membrane permeability. Your B2 cannot pass through lipid membrane. Then, with renal excretion, B1 cannot be excreted by your kidney. Okay, while your B2 can readily be excreted by your kidney. Then, with regards to the Van Denberg reaction, your B1 is indirect and B2 is direct. Synonym with regards to your B1 are non-polar bilirubin, unconjugated bilirubin, indirect reacting bilirubin, hemoglobin, hemobilirubin, hemolytic bilirubin. Okay? This is correlated with regards to your function of the bilirubin. Then, with the B2, it has a synonym of bilirubin diglucuronide, direct reacting bilirubin, prompt bilirubin, water-soluble bilirubin, polar bilirubin, and cholestatic bilirubin. Okay? Then you also have a delta bilirubin, a bilirubin that is tightly bounded to your albumin. So mainly, this is a what is the bilirubin which is bounded to your albumin? It's your B1. TB1 which is bounded to your albumin has a longer half-life than the other forms of bilirubin, formed due to a prolonged elevation of conjugated bilirubin or B2. Helps in monitoring the decline of serum bilirubin following a gallstone formation. Okay? So if ever that your gallbladder forms a gallstone, so there is not enough bilirubin being produced by the being secreted out by your gallbladder, then the delta bilirubin will be activated to supply that decline with regards to the bilirubin. Then your jaundice, a term which is known also as icterus. Okay? This is a condition wherein yellowish pigmentation occurs in your skin, mucous membrane, and even in the sclera of your eye. So ito yung nangingilaw. Okay? Due to the accumulation of abnormal amounts of either free or conjugated bilirubin or both of the forms of your bilirubin. Okay? Normal concentration of your bilirubin is 0.5 to 1 milligram per deciliter. A jaundice can be ruled out with regards to the result of 2 milligram per deciliter or greater than that. Okay? Classes of jaundice. You have prehepatic jaundice. This prehepatic jaundice occurs before the liver function. No? It doesn't have a correlation with regards to your liver function. Prehepatic jaundice can be caused by a excessive destruction of your RBC. That's why it is also called as hemolytic jaundice. Okay? Then also, prebilirubin is increased in the plasma. That's why it is also called as retention jaundice. Okay? Other factors that can cause prehepatic jaundice is your malaria, which destroy your RBC. Malaria, destruction of RBC also. Prolonged fasting or drug intake. Okay? Neonatal jaundice or rapid turnover of hemoglobin after birth. So, your neonatal jaundice is a normal phenomenon, but if ever that the infant doesn't um, normalize within 4 days, then there is something wrong with regards to the liver. Possible hindi makapag-cope up na yung katawan ng baby. sa pag-degrade ng bilirubin, increase in bilirubin. Kaya pinapaarawan yung bata. Anong correlation nun? Your bilirubin is photosensitive. Okay? When you say photosensitive, it is sensitive to light. It is being destroyed or degraded by your light. Kaya yung mga bata or yung mga infant, yung mga bagong panganak, ang ginagawa, pinapaarawan. Okay? O kaya nilalagyan ng ilaw, o warm light, para ano, ma-degrade yung bilirubin na nag-accumulate sa skin nila with regards to the infancy. Okay? Ano pa? Post-hepatic jaundice. This is also not related to the liver, but no, related to the tract of the bilirubin after being formed in your liver. Okay, so possible sa gallbladder, possible sa intestine, possible sa kidney, or any area of the body aside from the liver. No, after being formed by your liver. Okay, due to the obstruction of the biliary flow. Okay? Biliary flow, which is, no? Saan to? The bile duct. Okay, the bile duct of the gallbladder. Okay. No? Kaya, other term for post-hepatic jaundice is your obstructive or cholestatic jaundice, because of the obstruction of your biliary flow. No? This is caused also by your intrahepatic cholestasis. Okay? No, obstruct yung flow ng bilirubin into the gallbladder. How? No, possible yung bile duct, no, going to the gallbladder. This is your gallbladder. This is your liver. Yan, part of the liver. Sabihin natin. The part here is being obstructed, or there's a formation of stone in the area before your gallbladder. Okay. No other cause of your post-hepatic jaundice obstruction in that it's extrahepatic biliary tree. Okay. Which is by your gallstone or cholecystiasis. Okay. Strictures, spasms, atresia, parasite or bacteria, or even cancer of the pancreas can result to the obstruction of the biliary tree. What is the biliary tree? The biliary tree is the area wherein the liver, no, is connected to your gallbladder, and your gallbladder is also connected to your pancreas. So how? The tail of the pancreas touches the area of the hepatobiliary. Okay? Kaya if ever that there is a cancer of the pancreas, sabi dyan, no, especially in the tail, it can occlude the biliary tree, no, preventing your bilirubin from being transported from your liver to your gallbladder. Okay. Next, we do have the cholestasis or cholestasis. Okay. It is a hyperbilirubinemia with bilirubinuria, no? Presence of bilirubin, increased bilirubin in the blood, and presence of bilirubin in the urine. Okay. With a correlation of increased, no, ALP, GTP, 5-nucleotidase, and LAP, which are, no, this four can be known to be a part of your liver function test. Liver function test. Now, this test assess your liver function. Ano pang meron? Possible magkaroon ng hypercholesterolemia. Bakit? No? You don't produce enough bilirubin, no, due to the you don't produce enough bile No? That's why no emulsification of liver, no degradation of lipids, okay, is being done. Okay, kaya tumataas yung cholesterol natin. Okay? Also, high serum bile salts, cholate, and phenoldeoxycholate, no, are being found within the bloodstream. Differential diagnosis with regards to pre-hepatic and post-hepatic. Okay? Elevation of pre-bilirubin is correlated with regards to your pre-hepatic. Negative in urine bilirubin. Bakit? Before the liver. So your liver can degrade bilirubin back. Okay, and process it. That's why it is not, no bilirubin is found within the urine. Elevated urine bilirubin, urobilinogen, this is a degradation of your bilirubin, can be found in the urine. Bakit? No? Your intestine and your kidneys degrade the bilirubin to form this type of metabolite. Then, your stool is dark colored, also correlated with the urobilinogen. Okay? Kernicterus or deposition of bilirubin in the brain tissue may also occur. How? So your liver, okay, delivers blood into the heart, then your heart, no, delivers it all throughout the body. Okay? So, anong correlation nun? After the increase ng bilirubin in the blood before the liver, your liver will degrade it. Okay? Then, the liver will um, transport the excess bilirubin through the blood, okay, being degraded into by your other parts of the body. The brain is not excluded to that because of the blood contains also increased bilirubin, okay, which causes kernicterus. Okay, kaya nagkakaroon tayo ng elevated urobilinogen and darkly colored stool because of that. Okay, then on your post-hepatic jaundice, elevation of conjugated bilirubin or UB1. Okay, positive urine bilirubin. Bakit? No? This is after the liver. So, hindi na masyadong dinidegrade ng other parts of the body. Kaya nagkakaroon tayo ng presence of bilirubin in the urine. Decreased urine urobilinogen. Bakit? Kasi hindi na na-degrade si bilirubin by your liver. Kaya, bumababa yung urobilinogen. Then, clay-colored stool because of the decreased urobilinogen nga. Okay? Buo si bilirubin na excrete, no? Kaya walang pigment to give the stool color. Okay? This is known also to be your alcoholic or puty stool. Then you have also steatorrhea. When you say steatorrhea is the presence of fats, no? Lipids within the stool. Okay, bakit? The bilirubin is not degraded by your liver. It is not formed as to the bile. Kaya yung bilirubin causes decreased emulsification of the fats in the intestine. Then, your fats is being excreted to your stool. Kaya nagkakaroon tayo ng steatorrhea or fatty stool. Then, increased ALP and 5' nucleotidases. Classes of jaundice, you have also hepatic jaundice or hepatocellular or infectious jaundice. This is due to a severe damage to your hepatocyte. Both free and conjugated bilirubin is elevated. Sometimes this is due to alcohol or microorganisms that destroys your hepatocyte. Okay? Neonatal jaundice is also correlated with regards to the hepatic jaundice. This is due to the decreased activity of UPDGT after birth. So with your hepatic jaundice, we have classes or types. You have pre-microsomal, which is caused by your drugs, especially your rifampicin, which interferes with the bilirubin intake of the liver. So your rifampicin, a drug, TB drug, this is a TB drug. This is a TB drug, no, which inhibits the uptake of bilirubin by your liver. Okay, this interrupts with the function of the liver. Kaya this is a microsomal fact. A microsomal. Next is your microsomal. Prematurity correlates with the prematurity, hepatitis, inherited disorder of bilirubin metabolism such as your Gilbert syndrome and Crigler-Najjar syndrome. So when you say microsomal, the defect is found within the hepatocyte, okay, within the liver. When you say pre-microsomal, not related sa liver, no? How? Possible other factors are affecting the function of the liver, but in the microsomal, your liver has a defect. Okay? Prematurity, ibig sabihin, your liver is not matured enough, no, or your hepatocytes are not matured enough to do its metabolic functions. Hepatitis, your hepatitis is the inflammation of your hepatocytes or your liver, which no occludes the metabolic functions of your liver. Then inherited disorder of metabolism. Okay? Those are related with the liver itself. Then the post-microsomal, okay, this is really not also related with the liver, no? Majority of the cases are not related with the liver, but within the factors affecting the function of your liver, such as your impaired excretion of bilirubin. How? There's a um, obstruction of the biliary tree. Okay. Then drugs also. Methyltestosterone can occlude your release of bilirubin, inherited disorder of bilirubin, and metabolism such as your Dubin-Johnson syndrome. Hepatitis can also cause post-microsomal due to the no occlusion or obstruction of the hepatobiliary. Then intrahepatic obstruction, no? This is your this is caused by your hepatitis, cirrhosis, infiltration such as your lymphoma or amyloidosis, biliary atresia, tumor, or extrahepatic sepsis. Okay? So, in intrahepatic obstruction, the sinusoids, the caniculi, okay, and the bile ducts are being obstructed. How? Sometimes due to hepatitis of the inflammation of your cells within the liver. Cirrhosis, the death, no, causing fibrosis of the liver. Okay? Nagiging bukol-bukol na yung liver mo. Okay? Infiltration of lymphoma and amyloidosis. Okay? Ano to mga to? These are no agents that can occlude your bile. Bile duct and other areas that are transporting the blood. Okay? Biliary atresia, tumors, and extrahepatic sepsis. Okay. So you do have inherited metabolism disorder of bilirubin metabolism. First is you do have Gilbert disease or Gilbert syndrome. Okay, characterized by a mild unconjugated hyperbilirubinemia. Okay, your B2 is being accumulated, but in a mild state. Characterized by a decreased conjugation and decreased uptake of bilirubin. By what? By your liver. So, hindi na conjugate si liver ng bilirubin. Kaya, hindi na uptake or hindi nakukuha or na-receive ng other organs for other purposes. Okay? Increased B1 is associated with your Gilbert syndrome. Insertion of two bases into promoter region of the UGT1 A1 gene, resulting in lower transcriptional rate and overall lower enzymatic activity to conjugate your the bilirubin, unconjugated bilirubin. Okay? So next you do have Crigler-Najjar syndrome. This has two types. Your type 1 is an autosomal recessive, no? Absence of UDPGT, severe increase of B1 which causes death. Okay? Bakit nagkakaroon ng death? Since your B1 is increased, no possible, this can cause kernicterus or accumulation of bilirubin in the brain, which impedes the function of the brain. Okay, the type 2 is autosomal dominant, partial defect of the conjugating enzyme. So, ano problema naman ito? While meron kang enzyme but this enzyme is defective. Okay, and like your type 1, you don't have the enzyme at all. Okay, interest in B1, possible survival to adulthood can happen. Okay, kasi meron ka naman na enzyme, pero some of them are defective. Kaya possible yung survival in the type 2. Next is your Dodin-Johnson syndrome, characterized by a decreased hepatic excretion of bilirubin. So, increased B2 with hepatic pigmentation or melanin. Then, bilirubin excretion is deficit. So, mababa yung excretion ng bilirubin mo. Okay? So, this is a picture of your liver, which is necrosis. Necrosing. Nagkakaroon na ng cell death. Okay. Next, you do have Rotor syndrome. It is still unknown. Cause is still unknown. Similar to Jubin Johnson, but without hepatic pigmentation. Increased B2. Lucidistral syndrome, a familial form of unconjugated hyperbilirubinemia caused by circulating inhibitors of bilirubin conjugation. So anong defect ni lucidistral? Merong nasi-circulate na inhibitor of your conjugation of the bilirubin within the liver. Kaya nagkakaroon tayo ng B1 hyperbilirubinemia. Okay. Next is your liver diseases. Okay. So with your liver diseases, you have first hepatocellular disease. This is disease of the liver cells. Then you do have cholestatic relating to your biliary. This is a two broad categories. No? Some diseases include one or both types. Clinical features within the type may be similar irrespective of the specific order. Okay, why? Okay, sometimes your hepatocellular disease can cause cholestatic. Then your cholestatic can cause also hepatocellular disease. Kaya sometimes they are no specificity. Okay? So in your hepatocellular disease, your patient may have symptoms of what? Sometimes your patient is asymptomatic. Okay? No exhibition of your symptoms. Symptoms can also be seen as fatigue, malaise, anorexia or nausea, jaundice can also be observed, pruritus, easy bruising and bleeding, hematemesis, no, abdominal pain, swelling, day-night reversal, confusion, in worst case scenario, you have coma. Okay? So those are sometimes your symptoms for hepatocellular disease. While on your cholestatic disease, so your symptoms when can all your patient can also be seen as asymptomatic, but no, there is possible fatigue, malaise, anorexia, nausea, jaundice, extreme pruritus, extreme abdominal pain, and pancreatitis. No, also gray colored stool is present. Bakit? Your cholestatic disease relates to the gallbladder. Okay? So if ever that your gallbladder is defective, no production of urobilinogen, which causes your stool no, to be gray colored. Abdominal pain can also be seen. So yun lang, pinakaiba nila yung gray colored stool. Okay. Signs of liver disease. Possible, there are no abnormalities can be found, but your patient has already the disease. Okay. Hepatic enlargement can be seen. Tenderness of the liver due to the capsule distension. Nodular liver. Shrunken liver. Pag sinabi mo nodular, may bukol-bukol. Shrunken liver, lumiliit yung liver due to cirrhosis. No? Jaundice. Okay. Edema. Relative hypotension and tachycardia can be a febrile or hyperthermic. Also, you can see spider angiomata, palmar erythema, nail clubbing, Dupuytren contracture, testicular atrophy, and splenomegaly. Okay? So, these are your spider angioma. No? Parang nagkakaroon ka na, nagtuldok, then nagkakaroon ng parang, ganyan, nagkakaroon ng ganamay, yung rash. Okay, that's your spider angioma that can be related to a liver disease. Okay? Hindi mo siya makita, but yan. Nagkakaroon ng ganun. Para, nagkakaroon pa ng ugat-ugat ng kita. Okay? Then the nail clubbing, yan. Kaya sabi nila, nakikita kung may sakit kapag sa kuko. Okay, pag nail clubbing, this part, okay, yan, yan, the area before your nails, or the cuticle, this is the cuticle, okay, this is your nail bed, the nail bed is embedded within here, may nagkakaroon ng increase um, degree, so parang nagkakaroon ka ng club, parang naging mushroom yung itsura, okay, it's your nail clubbing, your Dupuytren's contracture, hindi mo na maigalaw yung finger. No? Nagkaroon na ng um, paninigas. Okay? Hindi na i-bend ng normal. Hindi na ibalik sa normal. Okay? Then you have the jaundice. Ayan, nakita-kita yung yellowish of the sclera. Your sclera is the whitish part of your eye. Okay? This is ascites. Okay? So, nagkakaroon ng um, accumulation of fluids within the peritoneal cavity. So this ascites can be a form of edema. Okay? Also ascites. Okay. What are the differential diagnosis for your liver? The common hepatocellular disease or can be seen as hepatitis. Your hepatitis can be associated with autoimmune, acute or chronic hepatitis, or even glomerulonephritis hepatitis. Okay. With the metabolic, you have hemochromatosis, Wilson disease, and amyloidosis relating to hepatocellular. The shock liver, fatty liver of pregnancy, and alcoholism can be related to hepatocellular disease. So next to be discussed is your hepatitis. So your hepatitis is mainly um, This part will mainly cover the viral hepatitis. Okay, so your viral hepatitis is known to have variation as to the virus being cause of the hepatitis. So for your A, which is infectious, okay, then B and D is found in the serum, which is also infectious. Enterically transmitted is your E. Parentally transmitted is your C. FG, TTD, and others are unknown. Okay? So this is a table showing you the different types of hepatitis as to the source of the virus, route of, route of transmission, the infection as to chronicity, and prevention. So your hepatitis A can be caused by your feces. Okay, those patients with having a hepatitis A, their feces can be infective. Kaya this can also be found in some of the foods. No? In the Philippines, we are endemic with regards to hepatitis A. Kaya lalo na yung mga street foods. Kaya tinatawag na hepaline dati yung hepaline. Yung area dun sa FEU. Kasi no, it can cause hepatitis because of the hepa A. Okay? Hepa A can also be found in your foods. Okay, this is a fecal-oral route transmission. Then the infection is not chronic. And this can be treated. Then prevention, pre and post exposure, and immunization. Okay, here, hepatitis A can be prevented through immunization. Next, your B. This can be this can be found in the blood, okay, bodily fluids, and other blood-derived products. This can be transmitted through percutaneous or permucosal. How is the percutaneous? So sa atin, we do have the needle prick. Needle prick injury. Okay? So inoculation of the virus within the skin. A breakage of the skin possible. No? Permucosal possible is via coitus. Okay, or sex. No, your hepatitis B can be transmitted through sex. Kaya this is a sexually transmitted disease. Madami din sa Pilipinas ang merong Hepa B. Kaya combo, if ever na meron kang Hepa B, you should be tested with HIV and even other STIs. Kasi dito sa Pilipinas, combo-combo ang STI. Okay, lahat, lalo na yung mga sexual, sex workers natin. Okay? Kaya practice safe sex, no? Your pills won't protect you at all if ever that you have multiple partners. Kaya use condom. Your condom is a safe for STIs, not only in pregnancy but STIs. Okay? The chronicity of the infection, this can be a chronic infection and cause hepatitis. Okay? This is a lifelong disease. They don't have treatment for your hepatitis at all. Okay? But the treatment is based on a supportive treatment. So if ever that you will exhibit coughing, you will just be treated with cough. Okay? Not by your hepatitis. Okay? Then prevention, this can be prevented via immunization. That's why healthcare workers are required to do immunization with the hepatitis B before being deployed in a health facility. Kaya lalo na mga before you're going to internship, magkakaroon kayo ng hepatitis B immunization. Okay? Okay, then you have the hepatitis C. Okay, this is also can be found in the blood or blood-derived products. Okay, or bodily fluids. This is also spread through needle prick or percutaneous, permucosal, as to your coitus. No? This is associated with regards to the co-infection. Then, no? how this can also cause chronic infection, the prevention, donor screening, blood donor screening, of course, risk behavior modification, be monogamous. Okay? So, same sila halos ni HEPA B. Then, HEPA C. So, your HEPA C doesn't have immunization yet. Okay? Kaya, ingat with regards to HEPA C. Okay? Then, HEPA D, same with your HEPA B as to the source of virus, route of admission, transmission, chronicity of infection, prevention, also same with HEPA B. This can also be related to co-infection. Then your HEPA E is also same with regards to your HEPA E. No, this can be from your feces. No, the route of transmission is fecal-oral or ingestion. The infection is not chronic. Prevention is ensure safe drinking water and food. They cook your food thoroughly. Okay, next is cirrhosis. Uh, cirrhosis is a clinical condition in which scar tissue replaces the normal tissue with regards to the liver. Okay, so your liver has a normal tissue, then there is a scarring. So scarring, nagkakaroon na ng fibrosis yung tissue. Nagiging parang bato. Okay, that's your cirrhosis. This blocks the flow of the blood through the organ and prevents the liver from functioning properly. So, mawawala na ng normal function yung liver if ever that there is a cirrhosis. Bakit your blood cannot flow within the vessels of your liver? Kasi nga, nagiging scarred tissue na siya. Okay, naninigas na, wala na contraction na napoproduce. Okay, signs and symptoms of this appear including fatigue, nausea, unintended weight loss, jaundice, bleeding from any gastrointestinal tract, intestine itching, and swelling of the legs and abdomen as to the edema. Okay. What are the other causes of your cirrhosis? So, chronic alcoholism can cause cirrhosis. Bakit? Your alcohol is irritating agent with regards to your liver. Kaya if ever that you are a heavy drinker, no, you are prone to cirrhosis kasi your liver is being irritated, no, always being irritated by alcohol, then your liver will um, respond to be scarred. Okay, chronic hepatitis C virus infection can cause cirrhosis. Hepatitis B and D infection. Bakit B and D? Because your hepatitis D infection can only occur if you have a Hep B. Okay? This is a co-infection. Autoimmune hepatitis. Okay, your liver itself is being destroyed by your body immune system. Okay? Inherited disorders such as your antitrypsin deficiency, Wilson's disease, hemochromatosis, galactosemia. Okay, non-alcoholic steatohepatitis, blockage of the bile duct, drugs, toxins, and infections can cause also cirrhosis. Okay, tumors. Now, primary liver cancer. This cancer is beginning within the liver cells. No, hindi nag-metastasize. A possible metastatic cancer occurs when tumors from other parts of the body spread or metastasize to the liver. Ano yung possible na nag-metastasize sa liver? Almost all because of the hepatic portal circulation. Okay, especially those organs below the liver. No? Your gastrointestinal cancer can cause liver cancer if metastasize. Kasi yung hepatobiliary tract or portal circulation is traveling through your liver. Benign, hepatocellular adenoma and hemangiomas can be considered benign, while your malignants are your hepatocellular carcinoma or your HCC, hepatocarcinoma, and hepatoma. So So, pag sinabi mong adenoma, this is benign. Pag sinabi mong carcinoma, this is a malignant type. Bray syndrome, preceded by a viral syndrome such as a varicella, gastroenteritis, and other upper respiratory tract infections such as your influenza. A characterized by a non-inflammatory encephalopathy and fatty degradation of the liver, mild hyperbilirubinemia, and threefold increase in ammonia and your aminotransferases as to your AST and ALT. This AST and ALT are part of your liver function test. Okay, is an enzyme detected within the liver function test. A drug and alcoholic related disorder, your immune mediated injury to the hepatocyte. Now, as I said, some drugs and alcohol are irritating to your liver. Drug induces adverse immune response directed against the liver itself and results in hepatic or cholestatic disease. Ethanol, or your alcohol, causes very mild, transient, and unnoticed injury to the liver. That's why if ever does that you are a heavy drinker, yeah, you can have cirrhosis or liver disease. However, with a heavier, yeah, prolonged consumption can lead alcoholic cirrhosis. Common cholestatic disease, extrahepatic biliary tree obstruction, your cholelithiasis, your cholangioma carcinoma, and hepatic cancer can cause extrahepatic biliary tree obstruction. Okay? Intrahepatic biliary obstruction is caused by your hepatocellular carcinoma, metastatic carcinoma, sclerosing cholangitis, primary biliary cirrhosis. Intrahepatic cholestasis, no, can be caused by your abscess from bacterial, fungi, or protozoan, or even in parasitic infection. Statins and just about any drugs can cause intrahepatic cholestasis. Next, what is the progression of your liver disease? So if ever this is the pathogenesis of your liver disease, okay, your liver is normal. If ever you introduce an irritant to this can advert to a fatty liver first. Okay, so example, if ever we do have alcohol here, your liver can be reverted to a fatty one, a fatty liver, or a alcoholic hepatitis. Okay, or even your alcoholic hepatitis can turn into fatty liver, and your fatty liver can turn into alcoholic hepatitis. Then your alcoholic hepatitis can either turn into liver cirrhosis, which eventually turn with liver failure, or immediately your alcoholic hepatitis will turn into liver failure. Okay, ano lang masasabi natin dito? All agents that can be toxic to your liver can cause liver failure. Okay. How much alcohol? So there is a threshold with regards to your alcohol consumption. Um, 80 grams per day or for 10 to 10 years, no, is your threshold for alcohol consumption. Anong equivalent nun? 1 liter of wine per day can be tolerated by your liver. 8 STD sized beer, standard size beer, okay, can be tolerated by your liver. Half pint of hard liquor can be tolerated by your liver. Excess of those can cause possible um, signs and symptoms of alcoholism and even can cause liver damage. Okay, among heavy drinkers, we do have, no, 230 grams per day times greater than 20 years. So what is that? 80% of moderate to severe fatty liver can occur. 50% of this is cirrhosis or pre-cirrhotic lesions found in the liver. So, if ever that you are greater than 230 grams per day, you are considered a heavy drinker. Then, no, you are 80%, um, you have 80% chance of having a moderate to severe fatty liver and 50% chance of having a cirrhotic and pre-cirrhotic lesions within the liver. Okay, so sometimes you do have fast days over slow years. When you say fast days, some individuals doesn't have a toleration with regards to your toxins being introduced to your liver that can cause immediate liver failure. Okay? But some, no? Yan. Inom naman, yan, isang beses lang uminom, no? Namatay agad. Bakit? Kasi the body cannot degrade alcohol or their body turn your alcohol into a toxic one or your liver cannot metabolize it. That's why it can cause liver failure and even death. Okay? Over your slow years, such as yung mga tawado, natin, ano, yung magtatagal ng nanginginom. Yan. Tagal na mamatay. Bakit? Kasi their liver can still non-degrade it, but there will be a limitation. Okay. So, clinical status of the liver. Bakit? Ganyan yung arrow. Sometimes nga, there is a curving. So, there's a slow progression. Feature here is your liver going to a cancer or cirrhotic one. So, your liver is a shiny, reddish organ. Okay? If it's fatty, magkakaroon yan ng yellowish streak. If it's fibrotic, it will have white yellowish scarring. Then in cirrhosis, it will have possible nodules, darkening of the liver, okay, and even in the progression of cancer. Okay, this is a human normal liver versus a cirrhotic one. Okay, mukha na siya, ito, shiny, smooth, yan, nakikita nyo dyan, shiny and smooth and healthy. And then in the cirrhotic one, no, parang may bukol-bukol, parang leathery yung texture. Okay? Okay. So you do have 12 scoring of the stages with regards to your liver disease. So you do have 1, 2, 3 parameters. So what are the values being evaluated by this scoring? You do have serum bilirubin, total serum bilirubin, serum albumin level, okay, their ratio, okay, and possible signs being seen in the patient as to ascites and encephalopathy. So number one score, okay, your serum bilirubin is less than 2 milligram per deciliter or less than 34 micromole per liter. So then your serum albumin is less than 3.5 grams per deciliter, okay, and the ratio is less than 1.7. So if ever greater than that, okay, it will proceed to number 2. And though there is no sign of ascites and encephalopathy in your 1. Okay? In 2, you do have total serum bilirubin of 2 to 3 milligram per deciliter or 34 to 51 micromole per liter. Then your serum albumin range to 2.8 to 3.5 grams per deciliter. Okay? And the ratio of them is 1.7 to 1.71 to 2.2. And greater than that will have 3, parameter 3. Then the signs being observed in your parameter 2, your ascites is controlled medically. So, nagkakaroon tayo ng intervention medically. Dinidrain yung fluid within the peritoneum. Then, encephalopathy also seen. Okay, dinidrain yung fluid within brain. Then, as a third parameter, greater than 3 milligram per deciliter ang serum bilirubin. Also, your albumin is greater than 2.8 dapat yan. Then, the ratio is 2.2. So, your ascites is poorly controlled and your encephalopathy is poorly controlled. So, prognosis, No, childhood A have a 80 to 100% survival, 1 year lang. Bakit 1 year? Kasi nga, their liver is defective. Yung childhood 2, 60 to 80%. Childhood 3 is 35 to 45%. Laboratory test related to liver function and diseases. Okay? So you do have non-specific. When you say non-specific, there this can be no related to other organs also. So your anemia, low platelet count, hyponatremia, hyperbilirubinemia, low albumin, elevated liver enzymes, elevated ammonia, elevated creatinine due to hepatorenal disease can cause increase in these variables, no? If ever that there is correlation with the liver, but this is not specific, no? Other abnormalities with regards to this can also be seen in other organs. So liver enzymes, ito, this is a definitive one. Okay, liver enzymes suggest hepatocellular diseases such as your ALT and AST or your alanine aminotransferase and your aspartate aminotransferase. No? They are previously known as your serum glutamic uh, phosphatase and your serum glutamic, I forgot SGOT. Okay, SGPT and SGOT. They are previous terms for your ALT and AST. So if ever that you are asked what is the other term for ALT, this is GPT. If at AST, this is SGOT. Pag may tanong, may sagot. No? Ask and sagot. May sagot. Ask and sagot. Kaya may pagbabalik pa rin yan. Suggest cholestatic disease. You do have ALT or alkaline phosphatase. Gamma glutamyl transferase is non-specific test with regards to your liver, but no, this is a significant rise in GTP can correlate with the liver, but not always. Okay? Enzymes have alternative source. Your ALP or your alkaline phosphatase can be seen in the placenta and bone. That's why increase in this no, doesn't always suggest cholestatic disease. Okay, we do have enzymes and markers of hepatic disorder. So for your hepatic disorder, with the correlation of acute injury or acute hepatitis and necrosis, there is an increase with regards to your ALP, AST, ALP, bilirubin, both grade 1 and 2, LD4 and LD5, normal total protein and albumin. Okay, in cirrhosis naman, we do have increased bilirubin, both B1 and B2. Ammonia is also increased. Okay? Slightly increased or normal with the correlation of your ALT, AST, ALT, and lactate dehydrogenase, your LD. Okay, decrease to low total protein and albumin, and increased globule. Okay, on your biliary tract obstruction, increased ALP, bilirubin, but only B2 is increased. GTP is also increased. Your 5' nucleotidase is increased, and your ALP is increased. Methods used in evaluating your liver function. So, determination of bilirubin are discovered using these methods. In 1883, you do have Ehrlich method using your urine samples. In 1913, you do have Vandenberg reaction. In 1937, Malloy and Evelyn. And then in 1938, Jurassic Graph. So, bilirubin are not free, no useful in neonatal population because of the presence of carotenoid compounds in adults, which correlates also in the yellowish pigmentation ni sapot. Kaya mas okay gamitin to with regards to babies. Serum Lectoid involves in measurement of reflected light from the skin using two-way blend that provide the numerical index based on the spectral reflectance. Microspectrometry that determine the optical density of bilirubin, hemoglobin, and melanin in the subcutaneous layer of the infant skin. So, mas okay ito sa baby since mas manipis pa yung skin ng baby and no, there is no interference of carotene which is found in your adult specimen collection and storage of your bilirubin. A fasting sample is prepared as to the presence of lipemia, pero there is no need for fasting. Okay? Your specimen doesn't require fasting, but if ever that your sample is lipemic, you will require fasting. Okay? So, kasi leukemia can cause increased turbidity, which results to increased bilirubin content. Okay, Himalay sample should be avoided, sinabi ko na, because of the release of your bilirubin within the RBC and the diazo reaction is also decreased. Bilirubin is very sensitive and destroyed by light. Therefore, specimen should be protected from light. Kaya meron tayong mga amber bottle tubes or amber tubes. Also, if ever you don't have your amber tubes, you can use ano ba to? Uh, we do have a paper. This is that specific type of paper. I forgot the paper, but you can use aluminum foil. And aluminum foil can be used as covering of the tube. Also, you do have yung blue na paper. Nagpa-copy sa Monsibo. I forgot the term for it. Okay? Yun yung mga ginagamit to cover it because your light can reduce your bilirubin 30 to 50% per hour. 2 days at room temperature, 1 week at ref temperature of 4 degrees, and indefinitely at 20 degrees Celsius. Okay, in Malay-Evelyn determination, the pH of your sample or the test requires 1.2. Methanol is the reagent being used. Okay? The reaction results into red-purple in color with a max absorption in the wavelength of 560 nanometer. As to your Jurassic graph, it uses caffeine benzoate as your reagent. Reaction on the alkot with diazo reagent is terminated by the addition of ascorbic acid. No? Alanine tartrate solution, which shifts the absorbance spectrum of the azobilirubin to a more intense blue color. So the reaction of this dendritic growth results into blue color. Okay? Then the wavelength being used is 600 nanometer. Advantage of Gendrastic growth over Evelyn, Malay and Evelyn. Your Malay and Evelyn, so your Gendrastic growth is not affected by pH change. For your Malay and Evelyn should maintain pH of 1.2 and an acidic environment. Okay? This is insensitive to a 50-fold variation in protein concentration of the sample. So your Malay and Evelyn is affected by protein concentration. Your Gendrastic growth maintains optical sensitivity even a low bilirubin concentration. So mas mataas yung specificity niya. And has a minimal turbidity and relative constant serum blank. It is also not affected by hemoglobin up to 750 milligram per deciliter. So hemolysis is not affect cannot affect the Gendrastic growth. Urobilinogen determination uses no para-dimethyl amino benzaldehyde or Ehrlich reagent which produces red color. Your ascorbic acid is being used as a reducing agent to maintain your urobilinogen in the reduced state. Okay, if ever that there is urobilinogen determination, no, it uses ascorbic acid. Saturated sodium acetate stops the reaction and minimizes the combination of other chromogens with the Ehrlich reagent. Okay, another your Ehrlich reagent again is your para-dimethyl amino benzaldehyde. Okay, this is used in the urobilinogen determination. Okay, that's all for your liver function. Thank you and good luck on your exams.